Understanding the Journey of Pregnancy, a comprehensive guide for nurses. Introduction. Welcome back to Wally's nursing videos. Today, we're diving into the intricate journey of pregnancy, from the antepartum period through the intrapartum stages and into the postpartum period. As nurses, understanding the physiological changes, nursing care, assessments, and potential complications at each stage is crucial for providing optimal care to both the mother and the unborn baby. Antepartum period. Physiology. During the antepartum period, the mother's body undergoes significant physiological changes to accommodate the growing fetus. Hormonal shifts, increased blood volume, and changes in organ function all play crucial roles in supporting a healthy pregnancy. The 3 trimesters of pregnancy divide the 9-month gestational period into 3 distinct stages, each marked by unique changes and milestones in both the mother's body and the development of the growing fetus. First trimester, week 1 to week 12. The first trimester is a crucial period of rapid development and adjustment for both the mother and the embryo fetus. Initial signs of pregnancy may include missed periods, breast tenderness, nausea, morning sickness, fatigue, and increased urination. During this trimester, major organs and systems of the fetus begin to form, including the neural tube, heart, limbs, and digestive system. By the end of the first trimester, the fetus has developed all major organs and is referred to as a fetus rather than an embryo. The risk of miscarriage is highest during the first trimester, which is why many expectant mothers choose to keep the pregnancy private until after this period. Second trimester, week 13 to week 26. The second trimester is often referred to as the golden period of pregnancy, as many women experience relief from early pregnancy symptoms and feel a surge of energy. Physical changes become more apparent as the abdomen expands to accommodate the growing fetus and the uterus rises out of the pelvic cavity. Fetal movements, known as quickening, become noticeable to the mother, providing a tangible connection to the developing baby. During this trimester, healthcare providers typically conduct routine prenatal screenings, including ultrasound scans to assess fetal growth and anatomy. By the end of the second trimester, the fetus's organs continue to mature, and the chances of survival outside the womb increase significantly if premature birth were to occur. Third trimester, week 27 to birth. The third trimester is marked by significant physical changes and preparations for childbirth. The fetus continues to grow rapidly, gaining weight and developing fat stores that help regulate body temperature. As the due date approaches, the mother may experience increased discomfort due to the growing size of the uterus, pressure on internal organs, backache, and difficulty sleeping. Braxton Hicks contractions, also known as practice contractions, may occur, preparing the uterus for labor. Healthcare providers monitor the mother and fetus closely for signs of labor and potential complications, such as preterm labor or preeclampsia. Labor typically begins with the onset of regular contractions and ends with the birth of the baby, marking the end of the third trimester and the beginning of the postpartum period. Due date calculation. To calculate the due date, commonly known as the estimated date of delivery, EDD, healthcare providers often use a simple formula known as Nagel's rule. Add 7 days to the first day of the woman's last menstrual period, LMP, and subtract 3 months. Alternatively, they may add 9 months to the LMP date. For example, if the first day of the woman's last menstrual period was January 1st, the due date would be October 8th. Adding 7 days to January 1st and subtracting 3 months or adding 9 months. This method provides a rough estimate of when the baby is expected to arrive, but keep in mind that actual delivery dates can vary. Ultrasound dating and other assessments may be used to refine the estimated due date and monitor fetal growth and development throughout pregnancy. Understand the following. Gravidity. Gravidity refers to the total number of times a woman has been pregnant, including the current pregnancy, regardless of the outcome. Live birth, stillbirth, miscarriage, or abortion. Gravidity counts each pregnancy as one, regardless of the number of fetuses, e.g., twins, triplets, in each pregnancy. Parity. Parity describes the outcomes of pregnancies that have reached 20 weeks of gestation or more. It is typically expressed in 2 numbers. Parity, P, the number of pregnancies that have reached 20 weeks or more, regardless of the outcome, e.g., live births, stillbirths. Gravida, G, the total number of pregnancies including the current pregnancy, whether carried to term or not. Term, Term refers to pregnancies that have reached or exceeded 37 complete weeks of gestation. Babies born at term are considered full term and are more likely to have fully developed organs and be ready for life outside the womb. Preterm. Preterm refers to pregnancies that end between 20 weeks and 36 weeks, 6 days of gestation. Preterm births can pose health risks for the baby, as vital organs may not be fully developed. However, with medical advancements, babies born closer to 24 weeks and above have a higher chance of survival and fewer long-term complications. Abortion. In obstetrics, abortion refers to any pregnancy that ends before 20 weeks of gestation. This includes miscarriages, elective terminations, and medical terminations for fetal abnormalities or maternal health concerns. Living. The number of living children a woman has given birth to, regardless of whether they were born at term or prematurely. This excludes pregnancies that ended in miscarriage, stillbirth, or abortion. Nursing care. Nursing care during the antepartum period involves regular prenatal assessments, education on healthy lifestyle choices, and emotional support for the expecting mother. Monitoring vital signs, assessing fetal growth, and addressing any concerns or questions are essential aspects of antepartum nursing care. Antepartum fetal assessment. Fetal assessment techniques such as ultrasound, fetal heart rate monitoring, and fetal movement counting help monitor the well-being of the unborn baby during the antepartum period. These assessments aid in early detection of any potential complications. Veal chop is a handy mnemonic used in labor and delivery to aid nurses in interpreting fetal heart rate patterns during childbirth. Here's a breakdown. Variable decelerations correspond to cord compression. These decelerations in the fetal heart rate are often irregular in shape and duration, and are associated with umbilical cord compression, which can briefly decrease blood flow to the baby. Early decelerations are associated with head compression. These decelerations mirror the contractions of the uterus and are typically benign, indicating pressure on the baby's head during contractions. Accelerations are a positive sign, indicating that the baby is doing okay. These are temporary increases in the fetal heart rate and often occur in response to fetal movement or stimulation, suggesting a healthy and responsive baby. Late decelerations signify placental insufficiency. These decelerations occur after the peak of the uterine contraction and may indicate that the baby is not receiving enough oxygen-rich blood from the placenta, potentially due to issues such as uteroplacental insufficiency or maternal hypertension. By remembering the veal chop mnemonic, nurses can quickly recognize and respond to fetal heart rate patterns during labor, facilitating timely interventions to ensure the well-being of both the mother and the baby. Antepartum complications. Complications during the antepartum period may include gestational diabetes, preeclampsia, placenta previa, and fetal growth restriction. Nurses play a crucial role in early recognition, management, and education regarding these complications. Let's delve into each of these topics. Ectopic pregnancy. An ectopic pregnancy occurs when a fertilized egg implants and grows outside the uterus, most commonly in the fallopian tube. However, it can also occur in other locations such as the cervix, ovary, or abdominal cavity. Ectopic pregnancies cannot proceed normally and can pose serious risks to the woman's health if left untreated. As the embryo grows, it can cause the fallopian tube to rupture, leading to internal bleeding and potentially life-threatening complications. Common symptoms of ectopic pregnancy include abdominal pain, vaginal bleeding, shoulder pain, due to irritation of the diaphragm by blood from a ruptured fallopian tube, and dizziness or fainting. Diagnosis is typically made through a combination of physical examination, ultrasound imaging, and blood tests to measure hormone levels. Treatment options depend on various factors such as the location and size of the ectopic pregnancy, as well as the woman's overall health. Options may include medication to stop the growth of the embryo or surgery to remove the ectopic pregnancy. Spontaneous abortion, miscarriage. Spontaneous abortion, commonly known as miscarriage, refers to the loss of a pregnancy before the fetus is viable, typically occurring before 20 weeks of gestation. Miscarriages are relatively common, with around 10–20% of known pregnancies ending in miscarriage, often in the first trimester. Causes of miscarriage can vary and may include chromosomal abnormalities in the fetus, hormonal imbalances, maternal health conditions such as diabetes or thyroid disorders, uterine abnormalities, infections, or lifestyle factors such as smoking or drug use. Symptoms of miscarriage include vaginal bleeding, cramping, abdominal pain, and passing tissue or clots from the vagina. Diagnosis is usually confirmed through ultrasound imaging and blood tests to monitor hormone levels. Treatment options depend on the circumstances, but may include expectant management, allowing the body to expel the pregnancy naturally, medication to induce miscarriage, or surgical interventions such as dilation and curettage to remove pregnancy tissue. Rh immunoglobulin, RIG for negative blood types. Rh immunoglobulin, also known as RIG or RhoGAM, is a medication given to Rh-negative women during pregnancy to prevent Rh sensitization, a condition where the mother's immune system produces antibodies against Rh-positive blood cells. Rh sensitization can occur if an Rh-negative woman becomes exposed to Rh-positive blood cells, typically during childbirth, miscarriage, ectopic pregnancy, or other events where there is a risk of fetal blood mixing with maternal blood. If a sensitized Rh-negative woman becomes pregnant with an Rh-positive fetus in a subsequent pregnancy, her immune system may attack the fetus's Rh-positive blood cells, leading to hemolytic disease of the newborn, HDN, which can cause severe anemia, jaundice, and other complications in the baby. RIG is typically administered around the 28th week of pregnancy and within 72 hours after events that may lead to fetal-maternal blood mixing, such as miscarriage, abortion, amniocentesis, or trauma. RIG works by preventing the mother's immune system from producing antibodies against Rh-positive blood cells, thus reducing the risk of Rh sensitization and subsequent complications in future pregnancies.